just if you think about your own sort of algorithm on what therapies you lean towards or lean away from, I'm going to say, for example, if you have a patient with MS, are there any particular therapies that you would try to avoid?
Well, Margaret and I were talking about this earlier, and I said, I just feel like there's not a cookie cutter approach, or like you said, an algorithm, because every patient really has to be evaluated fully. What are their comorbidities? What is their family history? Like an MS patient, right? That patient cannot receive a TNF inhibitor. So we need to know, do they have a history of inflammatory bowel disease? And IL-17 is not the drug of choice for that patient. But I wouldn't say that when we evaluate our patient, there's not this algorithm that we have to step through necessarily, because we have to take each patient into consideration and then evaluate it, as well as their insurance. If there's a Medicaid patient, even if there's a newer therapy, it may or may not be covered for that patient. So we have to sort of evaluate all of those things when choosing a therapy, I believe.
Right. And of course, there's a lot of drugs that, have absolute and relative contraindications. And we know that as clinicians, that we have to be very, very aware of that. And that's part of patient-shared decision-making. We need to have those discussions. They've seen a commercial on TV. They come in with this concept: I want this pill. I want, somebody was in a bathtub. They have these, and it's our responsibility to really do that good history to make sure, do you have a family history of MS? So there are things that we may have to push the limit. But the key is that we need to be educated and understand that. We need to fully assess the patient, and then we need to talk to the patient, and so that they fully are informed about the contraindications and about, like what Melody said before, what's probable, what's possible, and talking about the side effects. And then many patient preferences. Many patients come into my office and say, I do not want a shot. But they came through the door. And that's how I see it. And we have so many agents, and everything being equal, we've talked about this before, everything being equal, we have some amazing things. Or patients who are so remote, they don't want to have monitoring labs, or don't have the money to do it. So now we have these amazing new agents, that have minimal baseline laboratory screening. And so that's important, but assessing them, and especially with malignancies, exposure, especially to things like tuberculosis and hepatitis, and their personal lifestyle, whether it's alcohol or drugs, recreational drugs. So those are part of the decisions that play into
Or
there.
a potential pregnancy.
Absolutely.
You have to assume that because this is a young person's disease, so I'll just throw this out there right now. I expect, because most pregnancies are unplanned and they are going to happen, and you have to assume that females and males with this disease in their 20s, 30s, and 40s, and sometimes even 50s, that there could be a pregnancy. And there are some drugs that are absolutely contraindicated in pregnancy, and the only ones for me that are an absolute no-no would be methotrexate, acitretin. Those are absolute no-nos if pregnancy is a possibility. I would prefer to know if it was in the future and in the plans, because we have one biologic agent that actually has done a small study in looking at the impact of the drug on the fetus and on a baby through pregnancy and the nursing. And that is certolizumab, and I feel like that it's completely appropriate if somebody comes in and says, yes, I'm planning a pregnancy. Okay, let's start with that so I don't have to make changes. I've also looked at certain therapies and realized that they're about to turn 65, and I have to think about, what am I going to get covered for them? Because all things being equal, of the 11 options, which therapy would be good for them? Probably all 11 would help them tremendously, some better than others, but thinking, which ones am I most likely to get covered later, so I don't have to make a change and use something for a while, and then when they go into Medicare, change, and there are some that have better coverage than others. And even with the people who say that I don't want to have an injection, I'm just going to say most of the time they don't realize that, particularly if you look at 23s, you're talking about 4 to 5 injections within a year, and some can be done in the clinic and some they can do at home, so if they live far away. And the actual management of patients on you're asked to do TB testing before a patient starts any of the biologic agents. But the ones that we've had in the last decade, the 23s and the 17s particularly, they don't see anything about repeat TB testing. It depends on whether or not you feel like it would be wise. And the lab management of a person before they start, a lot of times they don't have primary care, and so you know the comorbidity, so you would love to know what their cholesterol is
Right.
and perhaps their blood pressure and their weight, because it can play a role with your dosing of particular drugs. But it also helps you see that overall picture.